The next presenter will be Dr. Vignesh. He's MCH from New Delhi, AIMS, and right now he is associate professor in PIMS, Puducherry, and his main interest is in the trauma registries, researching about transfusion requirements and hemorrhage protocols. Over to you, Dr. Vignesh.
Thank you, Ann. Thank you so much. So, that was a very Abhishek Sharma-like performance by Dr. Joseph. Flash everything out of the park. We difficult to live up to that, and I try my best to match that performance. The most common, once we talk about the abdomen injuries that we deal with are the liver and the spleen. So, so I will be talking a lot about splenic injuries, mainly concentrating on blunt trauma to the spleen. So more than 98% of what we see in our country is blunt trauma to the spleen, and very rarely do we have penetrating trauma. It is not there are no cases of penetrating trauma, but other rare scenarios. Given the time that we have, I think I would stick to blunt trauma to the spleen. So I will be talking about a brief introduction of splenic injury and the anatomy of the spleen. I'll quickly move on to grading of splenic injury and the modalities that will be used. And we'll be talking about specific management modalities of splenic injury based on the grade, based on the environmental status. And I will end by talking about the complications of splenic injury in splenectomy, and we will finally talk about the follow-up and post splenectomy prophylaxis. So the spleen is one of the most commonly injured organs in the body. Contrasting reports between liver and spleen being the most common one, but I think both of them are almost equal at this time. And it is one of the most common solid organ injuries that requires operative intervention. And a normal adult spleen weighs about 100 to 200 grams. All of us are very clear about the anatomy. The top being anti-left, the square being and the lower is being very close to it. And obviously the left and back end, but then the ligament is happen, and the body and side of the is in the this picture I want to show is basically the relationship of spleen with the to the lower rib, specifically on 9, 10, and 11 rib. So when your lower rib is left side are more prone, you will have injuries to the spleen, and for some reason will be injured. And coming to the blood supply of the spleen, the celiac axis gives out three major branches: the left gastric, hepatic, and spleen, which causes toxins over the pancreas and fixes the spleen. And the distribution is very either distributed or magistral. In 70% of cases, the blood supply is distributed, and as you can see in the first picture here, and some cases the magistral supply is distributed. And the venous drainage is the splenic vein, which forms the portal vein joint tree. I want you to all look at this diagram here. So this is basically the spleen and the most commonly how the spleen is injured. So the capsule is injured, and then most of these tears are usually a transverse tear, and that is why most of them do not bleed as much as one would expect. So based on the distribution of these vessels, which are very transverse in nature, and unless your laceration is in between these vessels, only then you have a extensive bleed. So Dr. Joseph has covered most of this with regard to initial management and the initial assessment of all of these patients. So one will stick on to the ATLS principles. Mechanical injury, like I mentioned, is very important, with about 99% being blunt trauma in our country. So one form is followed the ABCD principle of management, and one when one is evaluating circulation is one is trying to pick up for abdominal injuries or splenic injuries. Be very particular about. And EFAS is also something Dr. Joseph has touched upon, and I would completely agree with him saying that all surgeons or all the doctors in the emergency still not doing EFAS. We should know the technical know-how because it's picking up very minute or very major injuries at a very early stage. And definitely all these patients will be required to be resuscitated with some steroids or blood, preferably following a massive transfusion or management over this patient. So let's Uh, Assume the patient is a hemodynamically stable patient, like Dr. Lewis said, come to us and we diagnose that this patient has fluid on the abdomen. So the next line of management would be to make sure this patient is resuscitated to a level both based on his physiology, that is vital parameters, and also his lab parameters, more specifically his blood gases. Once that resuscitation is taken care of, and once this patient is taken enough condition, definitely a contrast sonography will be the next modality that needs to be done for all of these patients where a stent injury or any solid organ is being affected. So imaging is done basically in two phases at least, the arterial phase and the posterior phase. And if an injury is detected, or more specifically, if a vascular injury is detected on one of these phases, it is worthwhile that a delayed phase is also done to pick up any to differentiate between a solar aneurysm or an injury. So basically, the posterior phase is the phase where you pick up most of these injuries, intraparenchymal injuries or lacerations or hematomas, and the portovenous phase is where you identify the injury and start grading these injuries. Arterial phases are best used to diagnose pseudoaneurysms of the skin, and if there is a contrast leak, the delayed phase helps in differentiating between a pseudoaneurysm or an active contrast or else the bleed into the peritoneal cavity. So a pseudoaneurysm, the water contrast will be very rapid. You will not see any contrast in the delayed phase, whereas in an active bleed, delayed phase, the contrast cooling would be enhanced. So coming to, so once the PCT of the abdomen is done, we will directly go about grading the nature of the injury. So the mark classifies or grades clinic injuries, which is graded from 1 to 5. 1 is being least severe and 5 being the most severe. Grade 1 injury is subcapsular hematoma, which involves 10% area or a parenchymal laceration that is less than 1 centimeter in depth, or a very minimal capsular tear can be graded as a grade 1 injury. A grade 2 injury is where subcapsular hematoma is less than 50% and the 10 to 50%, and or an intraparenchymal hematoma, which is about it is less than 5 centimeters, or a parenchymal laceration, which is between 1 to 3 centimeters. A grade 3 injury is when one has a subcapsular hematoma of more than 50%, or an intraparenchymal hematoma of more than 5 centimeters, or a parenchymal laceration which is more than 3 centimeters. So these are the one can call grade 1 and grade 2 are something one can call a low grade injury, whereas a grade 3 and above is something one calls a high grade injury, splenic trauma. So you can see the arrow pointed at, which is a more than 3 centimeter laceration of the spleen, which is basically the grade 3 splenic injury. So this is a grade 4 splenic injury, and a grade 4 splenic injury is when there is a presence of a splenic vascular injury or an active bleeding. It is confined to the splenic capsule. Splenic vascular injury basically means a contrast leak. If it is confined to the splenic capsule itself, it is graded as a grade 4 injury. Or if there is a parenchymal laceration, it's segmental and because it's more than 25% devascularization of the spleen, it is a grade 4 injury. A grade 5 injury is when this vascular injury is extending beyond the splenic capsule into the peritoneum. So you can see with this yellow arrow that is pointed here, that can show that the contrast is leaking into the peritoneal cavity, and these are signs of active bleed that are present. And or when there is a grade 5 or a status spleen is also considered as the grade 5 spleen. Well, do any of these matter with regard to the management of these patients? The answer is yes and no. It depends on the setup that you're working at. But primarily, the management of clinic injury will depend on the hemodynamic status of the patient and the availability of resources at the time. So the hemodynamic stability or this patient is hemodynamically stable or unstable plays a very important part in the management of this patient. And obviously the availability of the resources that at your setting also is a very important key factor at this point. So the management can vary based on non-operative management or what you can call as an expected management, which can be augmented with the non-operative interventions or likely an operative management. So remember, our patient is a hemodynamically stable patient. So once we are very clear that our patient is hemodynamically stable, this patient is then subject to what is called a non-operative management. There are few things that one needs to be very wary about when picking out non-operative management. One is that the patient is hemodynamically stable. It may be for liver injury or spleen injury or for any other organ injury. This is irrespective of the grade of injury. One point that I want to push through is that if the patient is hemodynamically stable and it does not matter on the grade whether the patient plan for non-operative management. The patient did not have any signs of peritonitis. There shouldn't be any other injuries that require a laparoscopy. And always remember, there should be provision for abandonment of the non-operative management with these slight signs of deterioration. Prerequisites, like Dr. Joseph has mentioned earlier, is that one has to have facilities to take care of these patients if these patients deteriorate, which means that you should have facilities to have continuous and invasive monitoring for these patients. CECT, like I've mentioned, is a must before contemplating non-operative management, in which is that it gives you injury, it gives you an associated injury, whether we are dealing with something with regard to vascular injuries, all these things are easily picked up on a CECT of the abdomen. One should also have a well-stocked blood bank and a 24-hour operating room, along with an availability of an injury. So this 4-hour serious clinical examination is basically a combination of vital monitoring, physical examination, and this has to be about 4 to 6 hours for the first 48 to 72 hours, and then once every day from 72 hours till the date of discharge. There's no role for prophylactic antibiotics. There's no role for prophylactic drain placement in these patients. So the most important thing that one needs to do is physical examination, preferably by a single doctor, because the person knows how the abdomen feels, and if there's any change or any kind of hypertension or peritonitis, this may be a reason why one is going to abandon non-operative management. So it will also be based on your values, your hemoglobin and hematocrit values, and also blood gases will play a very important part initially in the 48 to 72 hours. It may be worthwhile to have basic coagulation profiles with you. If your institute does have viscoelastic assays or hotels or eggs available, it will be good to have them with you so that you can go ahead and transfuse this patient, or product specific transfusion can be matched to the patient. Target hemoglobins are again old recommendations for 10 for patients who are hemodynamically stable. 10 for patients who have risk of bleeding and hemoglobin of more than 7 who are hemodynamically. The most important thing of all of this is your physical examination, which includes both your vital parameters and the physical examination of the human itself. So that is what will drive you to tell you what.
So, like I've said, see, one has to be very wary when it's contemplating a non-operative management. One has to remember that most of these failures occur in the first 2 days or first 3 days of management. So this is the time when you are actively involved with these patients. One should also remember that higher grade injuries are more prone to failures, and one should at least keep these patients in hospital for at least 3 days before one can contemplate discharging them home. There are recommendations that say repeat imaging is required before discharge, that is at 48 to 72 hours. Preferably an ultrasound or a contrast enhanced ultrasound can be used. But if, like, these are advanced imaging which may require which depend on the operator itself. If someone is not does not have a very technical know-how of picking up pseudoaneurysms or AV fistulas or intraparenchymal lesions or intraparenchymal bleeds on an ultrasound, it may be worthwhile to repeat a CT in these patients, although it is not routinely recommended unless one has symptoms. So that is most of non-operative management. So once these patients are managed for the next 3 or 4 days, one can contemplate discharge in these patients. But some patients do require what is called non-operative intervention. And non-operative intervention can be of 2 types. One is a placement of a pigtail or a drain placement, and the second is in the form of an angioembolization. And this non-operative management can be used to augment non-operative non-operative interventions can be used to augment non-operative management. So why we place in a drain or a pigtail is when sometimes blood acts as an irritant and it can cause signs of peritonism. It may not be frank peritonitis. Patient may have no signs of tachycardia, no signs of hypertension, good urinary output, but still there may be an abdominal signs which tend to be favoring towards peritonitis or peritonism. That only at that point of time one can contemplate putting in a drain or a pigtail. Angioembolization, on the other hand, is a entirely different ball game. That is something specialists and you would need intervention radiologists with you to take care of this. But trust me, it helps you more often than not to have an angioembolization suit and somebody who's well versed in doing these procedures. So it may be, it is advised or indicated in patients who have active contrast leak, or when a pseudoaneurysm is detected on a CCT, or prophylactically in patients who have high grade of injury. This is a grade B or a level 3 recommendation. It may vary from institute to institute whether they go ahead and do it prophylactically or they wait and watch on these patients. But one should remember that the angioembolization itself depends on the ability of the patient to form clots, and it may not help in patients who are coagulopathic. So your patient should be able to form clots. That is where a viscoelastic assay or a TEG may be of help for you. And a splenic artery angioembolization leads to reasonably preserved splenic immune function. That is something that we should also know. So, like I've already mentioned, patients with vascular injuries are at very high risk of failure of non-operative management, and angioembolization is of great help in these patients. They reduce the failure rates in grade 4 and grade 5 injuries drastically. One should remember that there are 3 sites of angioembolization that can be done, and the 2 agents that can be used. 3 sites being either a proximal or a distal or a targeted or super-selective or non-selective one. The 2 agents that can be used are gel foam or coils. Being more specific to angioembolization itself, there's no difference between the success rate between whether it is a proximal or a distal angioembolization. Distal, quite contrary to what people think, distal angioembolizations are associated with higher chances of complications. That the complications mainly being necrosis and abscess formation, because you block off the distal segmental or one segment that gets devascularized, and that can go into infarction. Whereas a proximal, if you do a proximal embolization, there are small supply of collaterals from the short gastric arteries that tends to go and fill up these or perfuse the splenic areas. So a proximal embolization is what is recommended for diffuse splenic injuries, and distal embolization is kept to patients who have isolated vascular injuries or polar injuries. Gel foam again has a higher chance of complication in the sense that there is a higher chance of rebleed in these patients. So coils are preferred in these patients who have splenic injuries. So, like I've already mentioned, the complications of angioembolization include rebleeding, infarction, and abscess formation. If one does not have facilities for angioembolization and if detects a vascular injury on a CT, one should definitely contemplate going ahead with a splenectomy in these kind of patients. So, having covered non-operative management and non-operative intervention, this would be majorly for patients who are hemodynamically stable. Once we talk about and move ahead to the hemodynamically unstable patient is when we are thinking about operative management. Operative management, I usually like to put spleen as the third in order after appendix, gallbladder, and then the spleen, because one of the organs that is easily taken out. So it is majorly reserved for patients who are hemodynamically unstable, again, irrespective of the grade of injury. So the grade of injury does not matter at all. One should be taking a decision for operative or non-operative intervention based on the hemodynamic status. Or if the patient has peritonitis or signs of peritonitis, one should take up these patients for laparotomy. Or, like we mentioned, associated injuries which may require explanatory laparotomy. And definitely patients who have failed non-operative management, or you do not have the facilities for the same, one should contemplate operative management in these patients. Patients with coagulopathy, again, are a relative risk. So they should also be considered for operative management, in the sense one should have a low threshold to convert from non-operative management to an operative management, or if facilities not exist, definitely proceed with an operative. So operative management is a trauma laparotomy. So I have not gone through the specifics of it. I have maintained it to the spleen itself. Spleen salvage procedures are definitely not indicated in patients who are not hemodynamically stable. Irrespective of the grade of injury, when one is doing a damage control surgery, splenectomy is the option of choice. And for patients who have failed non-operative management, go ahead and do a splenectomy. There is no point in trying to preserve the spleen. Morbidity is definitely higher with splenic salvage. So I would personally recommend a splenectomy for a patient who's hemodynamically unstable, or a patient with a blunt or the solid organ injury who requires operative management to go ahead with the splenectomy. So operative steps are same for any trauma laparotomy, midline incision, three swipes into the abdomen. Make sure you've packed all your quadrants, eviscerate the bowel. The quadrants are unpacked one by one. And once you reach the spleen, or once you identify that the spleen is the source of your bleed, the mobilization of the spleen is the most important thing. One should be very systematic and careful in dividing the lienorenal and the frontocholic ligaments. And one should also mobilize the tail of the pancreas before one can take the spleen out. Care should be taken not to mobilize the left kidney along with the spleen. That is one thing. And one should also remember that the spleen has a very dual supply, in the sense that the short gastrics also supply, and the short gastrics are very notorious to bleed once the spleen is out, or even during an intraoperative or in the postoperative period. The splenic artery should be clamped as close to the spleen as possible, and one should remember to avoid the tail of the pancreas, and one should, especially when applying a set-in-city clamp, it should not be a blind clamp, rather a visualized clamp as to where the clamp is applied on the vessel itself. And a drain is left in place, and on day 3, a serum amylase would help, and a drain amylase would help in estimating whether the patient has a post-operative pancreatic fistula. Coming to complications, intraoperatively, like I've mentioned, there could be bleeding from the short gastric vessels, or there could be a pancreatic tail injury. One should be very wary about all the other complications of anesthesia and laparotomy, especially looking for atelectasis, pleural effusion on the left side, gastric dilatation, gastric wall necrosis. One dreaded complication is a postoperative pancreatic fistula, and one should also be very wary of rebleed or ligature slippages, and one should be cautious enough to put double ligatures wherever necessary. One long-term complication that we always talk about is your overwhelming post-splenectomy infections, although the incidence is very low. So the most common question that we get after non-operative management is a follow-up for these patients. How often do these patients need to be followed up, and when can they be discharged? So these patients can be discharged safely home after 3 days, provided all warning signs have been explained to them, and they are usually followed up on day 7, 21, 3, and 6 months of discharge. These are the recommendations by the Indian Society of Trauma and Acute Care. And the physical activity that is recommended is daily activities after 2 weeks, moderate activities after 2 months for low-grade injuries and 6 months for high-grade injuries, and contact sports is after 6 months for low-grade injuries and 12 months for high-grade injuries. And like I've already mentioned, there's no recommendation regarding the repeat imaging for all of these patients if they are asymptomatic. Symptomatic patients, it may be worthwhile to go ahead and do a CCT of the abdomen. Just touching upon post-splenectomy vaccination. So the most common organisms are capsulated organisms in streptococci pneumoniae, meningococcal and Haemophilus influenza. So vaccination against all of these organisms are recommended. They are usually given after 2 weeks of surgery or just before discharge, because most of these patients in an Indian setting, in a low socioeconomic setting, they may not come back to follow up. So it may be worthwhile to give them the vaccine before we send them out. One has to remember that the pneumococcal and the meningococcal vaccine have to be repeated at 5 years. The Haemophilus influenza vaccine need not be. And these patients, it may be worthwhile to give them annual influenza vaccines also. So this is something that needs to be considered. there's no role for long-term antibiotic prophylaxis in these patients, although there are some Australian guidelines which recommend antibiotic prophylaxis for the initial 2 years. It can be simple methoxypenicillin or amoxicillin once daily for 2 years in patients who are not immunocompromised, and lifelong only if the patient is immunocompromised. So to summarize, spleen is one of the most commonly injured solid organs. Initial assessment and management will follow the ATLS principle as per any blunt injury to the abdomen. The management of splenic injuries per se will depend on the hemodynamic status of the patient, irrespective of the grade of injury. NOM, again, is the treatment of choice for all hemodynamically stable patients, and operative management would be the treatment of choice for all hemodynamically unstable patients. NOI may be used as an adjunct to aid in non-operative management, and post-splenectomy vaccinations must be ensured in all cases who undergo. I'd be happy to take questions at this point of time or later.
Vignesh,
Yes, ma'am.
one particular thing I learned today, that a distal splenic embolization has got much more severe complications. I didn't know this. Number one. Number two, I wanted a little bit clarification. This damage in splenectomy, how far is it being done? Because spleen is such an easy thing that you just put a clamp and take it out, especially emergency splenectomy. How many times have we damage control? I understand for retroperitoneal, liver injury, spleen, or pelvic bleeding. But in spleen, I've hardly come across damage control in spleen. I have no idea about it. How far, what is the incidence?
So if one is a damage control laparotomy is basically a crash laparotomy. I think it's just an interchange of words. A spleen, if injured in a hemodynamically unstable patient, definitely needs to come out. There is no option of preserving that spleen. So it is close to it being irrational to try to save that spleen. So because that is, like you said, it is one of the easiest organs to be removed, and definitely in a patient who is hemodynamically unstable, the spleen needs to come out without a shadow of a doubt.
Okay. Now, what about this auto transfusion? Are they being tried? Is it only in trauma centers, or they can do some custom-made? Any centers doing custom-made auto transfusion? Any idea? I have no clue.
Customized and auto transfusions, I am not aware of, ma'am. But yes, auto transfusers are available in the best of centers. AIMS has an auto transfuser. If I'm not wrong, CMC also has an auto transfuser. So, but the problem is the logistics that is behind it.
Yes.
So the perfusionist is not available always on the floor, and all of this trauma comes in a sense. So setting up the auto transfuser actually takes about 15 minutes.
Okay.
So by the time you are in, the auto transfusion needs to be set up, and needs to be one dedicated person who's trained to do that, or a resident who's always learned to learned to do that, and who's always on the floor. These are the things. And the other thing about abdominal injuries is that sometimes there is always a possibility of liver injury also. So these auto transfusions cannot be used in liver injury because of the theoretical chance of bile leak.
Okay.
So that is the one thing. So if it is an isolated pelvic injury or an isolated splenic injury, yes, definitely. But even if the slightest doubt of liver injury or hollow viscous injury, so these auto transfusions are best avoided. One other place where auto transfusions can be used is thoracotomies. So yes, these are the two places that I think will be of best interest. But definitely the logistics is what stops from, and the cost for other institutes, because cost is something that everybody needs to consider.
One last point I wanted to add. This when a doctor is examining a trauma patient in a government hospital with certain X amount of facilities, he decides to refer, saying this is beyond us, fair enough. But when it comes to private and a reasonably stable patient at the time of primary survey, for him to predict, no, he's going to deteriorate, I'm going to send him off without any investigations, may not be practically possible. They are under severe pressure from the management and also from a senior who's probably not a trauma surgeon and who's not done the ATLS. Number one. So what I feel, everybody should be trained in ATLS. It sorts of empowers them to stand up, and people will. So this is what I wanted to tell. Everybody who's likely to see an emergency case must be ATLS trained, because I've been course director for ATLS. I find them much more empowered just at the end of the process of an ATLS training. They need not have seen an actual trauma case during the ATLS, and they may not see in future also. But when the situation arises, they are much more emphatic in deciding who can get the best treatment in their hospital, or they need a referral. This part of empowerment, I somehow found ATLS giving it to many, many students. And it is a way of pushing this program so that it reaches more and more people. Dr. Jagdish is here. He's course director for ATLS in Puducherry. Welcome, Dr. Jagdish.
Good evening, ma'am.
Thanks for joining us, Jagdish.
Sure, ma'am. Good to see everybody
Anything
else.
you want to add, Jagdish? Does anybody have any other questions?